Welcome to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Hello everybody and welcome to Khan's Health Hour. My name is Kemi and I'll be the host for today. I'm one of the GP trainees based in Manchester, but I'd like to welcome everybody to our Health Hour today. As they said, Health Hour is an opportunity for us to come together and learn from our medical experts within our community on different topics. So I just want to welcome everybody on all platforms, whether you're on Zoom, on YouTube, on our Zoom. It'd be great if you can put some comments in, telling us where you're from, letting us know whether you've joined before, whether it's your first time. It'd be great for you to just put some comments into the chat. Also want to just say that we're going to be having a talk on understanding and managing pain. So we've got an amazing talk going ahead this morning, and it's going to cover a wide range of things. It's going to cover management of acute and chronic pain. It's going to talk about why pain is under-recognized in the Black community, which I'm sure we'd want to hear a bit more about so that we can overcome that and work towards it together. And we've got an amazing guest speaker with Dr. Joanna David. She's a consultant anaesthetist who qualified in Trinidad and Tobago in 2001 and was appointed as a consultant in anesthesia in the UK in 2015. So she's got a wide range of expertise and we're going to be hearing so much knowledge from her today. I can see in the chat we've got some people joining us from Birmingham and they joined for the first time last week. So welcome again. It's great to have you here again. So just to give you a bit more information about Dr. Joanna David, who is our guest speaker. So she's got clinical interests that span in obstetrics and regional anesthesia, pain medicine, and patient education. And alongside her clinical work, she's actually a committed advocate in equity, diversity, and inclusion. So we've got a brilliant platform for her to tell us a bit more about that. And she's also served as a trust chair for the Culture and Diversity Network for the past 8 years. She's currently developing her leadership and management practice as an Elizabeth Garrett Anderson apprentice as well. So we've got a wealth of knowledge coming through from Dr. Joanna David, and the topic that we'll be on today is understanding and managing pain. So I just wanted to add as well, we're going to have a bit of a question and answer session at the end. So you can put into the chat box, whether you're on YouTube, Zoom, whatever platform you're on, put it into the chat box any questions that you have, and it's going to be monitored throughout, and at the end we'll run through all the questions. So without further ado, I'm going to hand over to Dr. Joanna David, a consultant in anesthesia. He's going to be speaking to us on understanding and managing pain. Welcome, Dr. David.
Oh, thank you, Kemi, for that very, very kind introduction. And hello, good morning, everyone. Welcome to this version of our Health Hour. Today, we're going to be speaking about understanding and managing pain. Let me just share the slides for us. We're just going to get right into it. So today, we've got a set of few sort of objectives just to guide the conversation. And so we're going to be having a little look at what pain is, what's the difference between pain and suffering, because that informs how we manage and view our pain. We're going to look at some of the types of pains, the more common ones, acute versus chronic pain. And then we're going to get into specifics for our Black communities, why pain is under-recognized, under-treated, and what the implications of that are for us as a community. Then we're going to look at some practical day-to-day things in pain management. What can you do, even whilst you wait for the medical fraternity to address your pain? And then we looked at some worked examples. We're looking at headache, back pain, and perhaps a slight little thing on pelvic pain. And then we're going to look at some myths, some red flags, and questions to ask your doctor, and a bit of safeguarding. Next slide. So what is pain? It's an unpleasant sensory and emotional experience. It's usually linked to harm. Somebody takes a knife and you cut yourself in the kitchen, you fall over, roller skating or something, you hit something. It's a signal to the body that something is wrong and that you need to either remove yourself from the situation, get away from what's hurting you, or protect that part of the body that's been hurt so it's no longer hurting. But pain is also shaped by emotion and context. The things to remember is that pain is always subjective. We have a saying in pain medicine that pain is what the patient says it is. Nobody can test your pain. If I get a cut on my forearm and you get the same thing, we can experience that pain very differently. And so nobody can measure your pain and tell you it's more or less than it should be. You are the judge of it. And you need to remember that. Pain is also, as we said before, a protective signal, warning of harm, and it's shaped by context. For example, if, I'm hit by, by a ball in a cricket ground, I will just say, ouch, and I'll keep it moving because I'll make sure that I'm okay. However, if you come from a context where that was used to terrorize you, people hit you with balls as you pass by, that fear can worsen the pain that you feel when that ball hits you. And in pain medicine, we call it the biopsychosocial model of pain because it's not just the thing that causes the pain, which is the biological part, but it's also shaped by your social context. And that will help how you experience the pain, or it will inform how you experience the pain. Next slide, please. So there are two common subtypes, acute pain and chronic pain. Acute pain is usually of sudden onset, and it's got a clear cause. And it's usually, so we talked about somebody being cut by a knife in the kitchen. So if that happens, you expect that pain to resolve once that cut has been resolved. You've bandaged it, you've stitched it, whatever you need to do, taken some stuff, and you expect that pain to go. Yes? So sometimes, though, it doesn't go. Sometimes, because of how we experience pain, or perhaps a nerve was damaged, the pain that you get from it outlasts the injury, and it evolves into chronic pain. So sometimes the nervous system and the way that it experiences pain can change, and even though that cut heals, you will feel that forever. And so then we get into the discussion about how we manage pain that's not caused by any physical condition that can be fixed. And we'll talk about that a bit later. Next slide, please. So now, as part of our definitions, we look at what is suffering. And suffering is that part of pain that is the distress that you experience because you can't control what's happening either to yourself, to your environment, or to everything around you. And it's got like an entire social context. It's about your experience of what you are going through. And that will differ for everybody else. So even if, like we were saying before, you've got a small wound, the suffering that can cause because you are thinking, I've injured my leg, I can't go to work, what's going to happen to the family? How are we going to earn? All of those things are part of suffering. So it's your experience, not just of the actual pain, but of the entire context of your life that may be affected by it. Next slide. And so we look now at the hidden disparity about Black pain in a world that was not really made for us. Next slide. Next slide, please. So the evidence is consistent. Oh, sorry. Can we go back one? The evidence is consistent. 66% of patients presenting as an emergency room who were Black, they were 66% less likely to get no pain medication, even though they had broken bones. And the source for that is from the Annals of Emergency Medicine, and this was done in 2019. They looked at Black versus white patients, even when they did get pain relief, 57% versus 74%. So we're 40% less likely to get pain relief than our white counterparts. And this research is consistent across decades of research, multiple conditions, and multiple age groups. It doesn't matter if it's children, because the Guardian newspaper a couple of months ago published an article about Black children and appendicitis. Not only were they not believed that they were ill, their pain was not believed, so the appendicitis was discovered and diagnosed at a much later stage than white children. But following surgery, they did not give Black children the pain relief that they needed, even though they knew that they had surgery. And so it does matter. Next slide, please. So where does this bias come from? In the 19th century, there was this thing called race science. It was, slavery was still around. They wanted to have further evidence, quote unquote, that, Black people were less than, that, the things that they were doing to them, whipping, etc., that was okay. And so a lot of false claims came out of that context, that Black people had thicker skin, less nerves, less sensitive nerves, faster clotting blood. So even if you hit somebody and they bled, they'll be all right because they can clot faster and they'll heal. Of course, none of this is true. And yet it shaped the medical belief for generations, because this was also the period in time when modern medicine was being developed. There was a lot of experimentation without anesthesia, and a lot of the foundational surgeries we now take for granted were developed, especially in the field of gynecology, without consent on enslaved Black women without anesthesia. And a lot of these things were justified by the false belief that they did not feel any pain or they felt less pain. And based on this history, next slide, the problem is that the bias hasn't disappeared. In 2016, the University of Virginia found that their medical students still believed that these things exist. About 50% of them endorse these beliefs that we just spoke about. And the problem with this belief is that if they don't know that, or they believe that, then they don't believe that Black people are in pain. Because remember, pain is a sign that something is wrong. Then we don't get diagnosed with things. No, you don't have that. You go away and 10 years later it's cancer, but nobody believed the pain that you were talking about. That's why it matters. Even with patients with acute pain, they ranked their pain scores as lower and gave them less treatment. So the bias shapes whose pain gets charted, whose conditions become diagnosed, who is believed, and who gets treated promptly. And that's why it's important. Next slide, please. And so we talked about this just now, about the delayed diagnosis, undertreated conditions, higher risk. But another thing that happens is that it erodes trust between our communities and the healthcare system. Because if you go to somebody constantly saying, this is what's happening to me, and nobody believes you, nobody acts on it, it makes people less likely to seek care again. And even if they do seek care again, the manner in which they interact with the healthcare system becomes warped, and they're likely to have poorer experiences. And so they call it the disbelief and distress cycle. And so we need to be mindful of that. Next slide, please. So bearing that in mind, we're going to look at some strategies for managing pain. So acute pain it's relatively easier to manage than chronic pain. Because in acute pain, we know that it's usually caused by something we can see, something we can know, it's very recent, and we usually know what has happened. So what do you do if you have acute pain? If you know that you've cut your finger or you've strained a muscle, you rest and you protect the area. You can use ice for swelling, gentle heat for stiffness. Please, guys, never put ice or heat directly onto your body. Always make sure if you are using an ice pack or a hot water bottle, wrap it in something for protection. Don't put it against your skin because you run the risk of burns either from the cold, extreme cold or extreme heat. The second one is really important. Move within limits, gentle movement. Yes, especially for things like back pain. People tend to go running to the doctors for back pain. Back pain we'll discuss later. But as long as you can move, you can get up, you can have gentle things. We're not talking about fractures or burns or anything like that has other treatments. But in terms of musculoskeletal conditions where you feel a bit stiff, where you feel a bit painful, just gentle movements every day, stretching your arms above your head, bending over gently, just be gentle with your movement. It improves your circulation and it prevents you from getting stiffness and prevents your fascia from contracting and making it more difficult later on. Take medication and schedule as prescribed. Now, a lot of people, and this is key, will take the medication when they feel pain if they've got an acute pain condition. What you want to do is take your medication regularly. Because if you think about it, you swallow a pill, the concentration in the blood is going to go up, and then it's going to come down as the body gets rid of that pain medication. What we want is the concentration in the blood to go up and stay up. So if they tell you, for example, to take paracetamol 4 times a day, please take it 4 times a day, because what's going to happen is if you take it once a day and then you wait for the pain, by the time you've taken the second dose, the blood concentrations are already low and the pain is rising, and then you're always chasing that curve. But if you take it regularly, you are more likely to keep the pain away, and so you'll be able to move a bit better, have better relief and a better experience of that, whatever it is you're going through. And then track the pattern. Notice what triggers it and what eases it, and share this with your provider, because this can give them vital clues as to what the condition is if they're not quite sure. Next slide, please. So chronic pain is a bit different. In the chronic pain, the nervous system has sort of taken over from the acute pain, and it's telling your brain that something is hurting when it's actually not injured or hurt. And the key is to pace yourself. Sometimes people get frustrated because the pain is not going away. Just remember, take it slowly, do your slow stretches, and avoid what we call that boom and bust cycle, where you have a burst of energy, then you get fed up and disheartened, and then you do nothing at all, and then you get really stiff, and then you try, because your functionality goes down with every rise of that boom and bust cycle. The key to chronic pain is a pain management program. If you have chronic pain and you have not been referred, please ask your GP or whoever's looking after you in the tertiary centre to refer you to a pain management program. These programs usually last about 6 months. And they combine physical therapy, so you know that movement we were talking about, the medical care. If there is an underlying cause, they will take care of that as much as they can. But most importantly, mental health support. And I know sometimes it's something our community runs away from. Psychological help, mental health support. I'm not crazy. It's not that you're crazy. It's just that you are experiencing something that's really affecting your life. And sometimes the mental health support can help you not just cope with it, but live well with it. And so I think that pain management program, if you take away nothing else from today and you have chronic pain, please, please, please request to be on one if you've not done one already. Protect your sleep like it's paying you. Poor sleep raises pain sensitivity, And sometimes if you get under your sleep and you sleep well, it can ease the pain because it's part of that suffering thing that we talked about, that suffering cycle. So just make sure that if you can, sleep well, go to bed earlier, time your pain medication so that you sleep well and that you're not awake. And if you struggle with that, contact your healthcare provider and see if they can help you with that problem, if it is that it is caused by pain. Keep a pain diary. Very, very, very important. Very important, because it logs not just your symptoms, but when it happens, the intensity, whether it gets worse with stress. So there may be psychological triggers, because remember we talked about suffering contributing to increasing pain. So all of these things will help, because when you get into the pain management program, you will know what triggers you, and then therefore what you can do to decrease that suffering. Next slide, please. So we're going to look at a few common conditions and a few things you need to be worried about. So headache is very, very, very common. Some people have migraines, tension headaches, which are the most common, lack of sleep, you have a new baby that won't stop crying, you're not getting any rest. So generally, for things like tension headaches, sleep and stress management can help with the occasional over-the-counter pain relief. If it is migraines, most of you who have migraines know what triggers it, and you know that rest in a dark room, early medication, for some people sound can trigger it, so quiet rooms. You track your triggers and you can address those. Cluster headaches are different. They tend to be very short and severe. And if you are having those, you need to go to your GP, who should refer you to specialist care. But please monitor your medication use. Things like if you use medications for pain for more than 10 days a month that are unprescribed, that's over-the-counter medications like paracetamol, ibuprofen, etc., they can cause more headaches, especially if you stop them suddenly. You can get rebound headaches. So just be aware of that. As a matter of fact, if you're using pain medications for headaches for more than 10 days, you should seek medical care, because that is not normal. Again, persistent medication use can cause renal problems and they can cause stomach ulcers. So although we are saying, yes, you can use gentle over-the-counter medications, they should not be used, I would say, for more than 3 to 5 days before going to seek somebody. That is if we don't have any of the red flags we're going to mention. The thunderclap headache, which sounds exactly what it is. It's like a clap, a thunderclap. It's sudden, severe, and described as the worst headache of your life. And it happens within seconds. That is a medical emergency. You need to go into the emergency room, not to your GP. If you have a new headache after age 50, that's different, or during pregnancy or the postpartum period, please seek help. If your headache is accompanied by fever, a stiff neck or a rash along with the headache, we're thinking things like meningitis, that's a different kind of headache, please seek help in the emergency room immediately. And do not let anybody dissuade you or from getting treatment or send you back home. Confusion, weakness, and visual changes or seizure. Commonly signs of a stroke, maybe other things going on in the brain. If your headache is accompanied by those, you need urgent emergency room help. And if the headache is worse lying down or with straining or wakes you from sleep, again, you need to seek help immediately. Next step, please. So back pain is another common thing that people experience. We talked about staying active and keeping the muscles moving, because resting in bed can slow your recovery. So gentle movements, gentle forward bends, back bends, side bends. You know, we're not going to the gym and getting at it. We're just doing gentle moving. Heat we talked about, and how to use heat, as well as sometimes if it's you know, you've done something to the muscle, gentle cooling with an ice pack wrapped in something gentle, a cloth or a towel onto the area, can help to ease these flare-ups along with the over-the-counter drugs. Most acute back pain will stop within 4 to 6 weeks. If it persists, you need to get more assessment. Even if you've got chronic back pain, surgery is not the answer, and almost always, in about 60 to 80% of patients, will worsen your back pain unless there is a specific anatomical problem that's visible on MRI or CT that can be fixed. So I know a lot of people, when I first entered medicine, having back surgeries were very, very common. But looking at the evidence is not always the answer. So it's just, so that people can adjust their expectations of surgery for back pain and what it's going to do for them. So the red flags around back pain: if you have new numbness around your groin or inner thighs, or if you have bladder or bowel changes, that is, either you can't hold your urine or stool, or you can't evacuate your bowels or bladders. Either way, that is a red flag, and you need to seek urgent care as an ED, emergency department care. If you notice persistent weakness or numbness in your legs, or fever with back pain, especially if you have a history of intravenous drug use, please, please, please go to the emergency room. Unexplained weight loss, or a history of cancer is another red flag. And if you are in a car accident, or you've had some other form of trauma, or you are an older person with osteoporosis and you've got sudden severe back pain, please, that's an emergency and you need to seek urgent care. Pain that does not ease with rest or wakes you at night, again, you need to seek help care about that. Next slide, please. So a few myths that we need to dispel. I think sometimes we, especially in our communities, see stoicism as a virtue. And so when you're in pain, I can bear that. I can get through that. However, sometimes by doing that, we actually worsen whatever it is that we're trying to cure. So please take any prescribed pain medication as directed. We spoke to you about that before. It will not turn you into an addict, even if it is an opioid or an opiate, which is like a morphine type medication. The fact is, sometimes your body gets dependent on it, which is your body adjusting to the dose we've given you. And so you might need to increase your dose for the same effect if you have chronic pain. That does not mean that you're addicted to it, and you should be being monitored appropriately. And so the risk of addiction is relatively low if you're monitored correctly. The myth that if it isn't opioids like morphine, etc., it isn't real treatment. As we've just talked about, many non-opioid options like the paracetamol, the ibuprofen, the diclofenac can help. There's some pain nerve medications. For example, there are groups of drugs like we call them serotonin uptake inhibitors. They can help as well. Physical therapy or PT works really well. And so you have to combine all of these things to get the best out of your pain relief. Asking for adequate pain relief makes you drug seeking. You're not drug seeking. You're seeking help for a problem that you have got, a very real problem. And it is a particular bugbear of mine when I get down to the ED and I see people suffering and they were like, well, and they say it to me, you know what these people are like. They're always seeking drugs. Yeah, have a moment and then we carry on and make sure that they get their correct medication. Especially we find this in our sickle cell community, even though people know that people in our sickle cell community have absolutely painful crises, they will still come in with their plan that they need morphine at this rate, that rate, and they still are called drug seeking. But many of us still think that it makes us drug seeking. Neither is true. You just need to ask for what you need. It's not a character flaw. It's not that you can't cope with simple things. We need to make sure that we get the pain relief that we need when we need it. Next slide, please. Next slide, please. Oh, right. Questions to ask your doctor. So I think another important part of this is we need to have a bit of self-advocacy. So how do we do this? If you need to take action, like we said, you have your pain diary, and when you get to your doctor, you ask him or her, what can be causing this? Is there a test that we can have to confirm it? Or if we can't confirm it, can we exclude it? And if, whether the answer is yes or no, if you say that you can't do anything, then what does this look like in 2 weeks, in 3 months? If it's untreated and I'm still in the same position, what's the plan then? What are we going to do? So that it develops an expectation between you and your doctor that we have a timeline. If it gets better, it gets better. If not, this is what we're going to do. That's what we're going to do. And it sort of puts your mind at ease that you're not just going to be let out into the wild to suffer, because you know that there is a plan if this thing doesn't work. And if it does, great, then we get on with life. Ask about all the options, not just medication. So we spoke about physical therapy, keeping moving, gentle exercise, cold, hot compresses, all of these other things, psychological help for those who suffer from chronic pain. Now remember, pain is a symptom of something. Sometimes in chronic pain, it is also a symptom. We have the examples of endometriosis, yes, which is very painful and persistent. So sometimes it's not just about managing the pain. The pain is just there. And in anesthetics, you have this thing where you support the patient while you treat the underlying cause. Yeah, so we need to treat, in a lot of cases, the underlying cause. So that pain should be a trigger to go back to number one, what is causing this and how can we confirm it? Yes. So in a case, for example, like endometriosis, which I think it's still about 13 years before any woman, regardless of race, is believed, and it's persistent and pervasive. And it doesn't end at menopause, the way some people think it does. So it's really important that we get that right, and that we're on the right medication that will suppress or manage the condition, depending on your stage of life and what you need, whilst we're getting the pain medication right. So your option will definitely include a diagnosis and as well as medication. And then you ask them to document their pain level and symptoms in your chart today. And I would encourage you, if you have any, the NHS app, or you have access to your GP notes in another form, because they use several different applications, computer applications and programs. Read your GP notes and see what they have written. If they have not written what you've told them and they minimize what you said, you need to get onto that GP practice manager and say, hang on a second, I asked them to document my pain level so that we can have it somewhere tracked. This is what I've seen in my notes. This is incorrect. I need you to address this. And that's important, because if your GP is documenting, or your doctor is documenting your pain incorrectly, then when they look back or somebody new comes, they're going to get a very different idea of what you are experiencing that can be far from the truth. Aside from being illegal and untrue, and that's very serious, because it can delay your management and diagnosis if it's something underlying your pain. And then you ask them, what symptoms should bring me back before my next appointment? Okay. If you feel dismissed, ask for it in writing, ask a second opinion, or bring in a support person who can be your witness. Next slide, please. So you may have heard of Martha's Rule, which is a right to be heard. And it's the right to request an urgent independent review if your concerns aren't taken seriously. Now, we have to be wise in how we use this. You know the history of Martha's Rule. It was meant for in-hospital, acutely ill patients, and it's live in most English hospitals now. However, the principle of Martha's Rule has been extended to other things. So it matters for pain, because if you have worsening or unrelieved pain, it's often the earliest sign that something is going wrong. It's not just something to endure. You can ask for a second opinion, especially if you are in an acute emergency room situation. you have the right to invoke Martha's Rule. And if you invoke it and they don't listen, the trust is liable for that legally. Yes? So, and if it is you feel like you're being palmed off because it just got somebody in the next room to come and echo what they've said, they were like, no, you need a consultant review. That's what you need. It's a formal route to a second independent opinion, and it's valuable for those whose pain reports have historically been minimized. So be wise about how you use it. You know, if you've been in, you know, if you bumped your knee for 3 days and it still hurts, please don't do that. But, you know, if it is that you have pain that is severe or even moderate, and you think that something is going wrong with you, it's not necessarily the pain that you might be invoking it for, but you're worried about what is underlying the pain. So please remember Martha's Rule. Next slide, please. So you deserve to be believed, yes? Pain is real. It's worth taking seriously. Knowing the historical context, especially of our community, and why we need to advocate probably more than other communities, how we can advocate, it helps to close the gap. And so we hope that this has helped you to sort of get that context and how to close the gap. Next slide, please. So I'll just say a quick thank you and open the floor for questions.
Thank you, Dr. David, for that really insightful talk on understanding pain. I think we can take a lot of lessons from that and things that we can go ahead and implement in our lives going forward. We do have quite a few questions on our Zoom chat, so I'll get right into them. So I'll go from the beginning. We've got a question here that's asking how to manage cervical spondylitis. The pain is unbearable and I've had this condition for 3 years.
So I appreciate the question. I think we might get into a bit of trouble if we start answering specific medical questions where we don't have the full history. We haven't done a physical examination, have no access to scans, because we need to see those in order to get a plan that works for you. And so I don't want to minimize the question, but at the same time, I wouldn't be doing you a service by advising you now. What I will say is, I would put the question to you, who's managing it? Who knows about it? Have you been referred to a specialist, neurologist or neurosurgeon for that management? And if not, you probably want to start with getting to your GP about that. And whilst you wait, because a lot of the referral times are quite long now, I would ask that you be referred to a pain management program, because sometimes even if you don't have access to these people who can help you with the neurological side of it, getting into the pain management program, there will be a subspecialty physiotherapist who can probably get you in earlier, because if they see that you have signs and symptoms that need addressing, they will go back to their home team and say, this person needs to get in. So it's another way of getting into your into the care that you need. But in terms of giving specific guidance for that, I won't be able to do that because I don't have the information that I need.
That's understandable, but you can still work in the background pushing for physio and trying to get through that way as well. Another question. I've had lower back pain for years and my GP just keeps telling me to take paracetamol and use the physio app. At what point should I be pushing for more than that? Maybe private care?
So if you are entitled to an independent opinion. So that's the first thing. So you go back to Martha's Rule. If it's pervasive, if it's long-standing, if it's getting worse, you can say, look, you said this to me. Can I have a second opinion about this, please? Or if you haven't been scanned yet, you haven't had any scans, you can request to have a scan of your back done. Now, if there are no symptoms associated with that back pain, the chances of them doing anything surgical to relieve that are low to none, because as we said earlier, most back pain is musculoskeletal, unless you've got other problems underlying that, which a scan will reveal. If there are no underlying problems, then we go back to physiotherapy and pain relief and the pain management program. It's not a very satisfactory answer for a lot of people, but as I said, the research has shown that if it's just isolated back pain with no anatomical correctable abnormalities and no underlying problems like metastatic cancer in your spine, or a disc that slipped in the back, or something that's there, if you go in and do stuff, your pain usually gets worse and it does not help. So I think if you haven't been scanned, then perhaps push for that and a second opinion. But unless there are other things going along with it, bladder and bowel problems, weakness in your legs, pins and needles in your legs or something, then it's unlikely, even though you get scanned, that they're going to be able to do anything surgical for it.
Okay, thanks for that advice. We do have another lived experience comment here that says, I had neurosurgery a week ago, and while on the neuro ward, it was exhausting advocating for proper pain management. They prescribed me paracetamol and IV fluids. When I said I was still in pain, they gave me an ibuprofen tablet. I felt like I was drug seeking, as I had to keep saying I was still in pain. The last time I had this surgery, I was given oxycodone on the ward and discharged with it. It makes me not trust that my pain will be managed the next time I have to have surgery, which is in a few months for endometriosis.
I hear these things and I get tired because it's persistent, it's pervasive. I'm really sorry that you had to go through that. Paracetamol and ibuprofen is not enough for what is in fact major surgery. However, I've seen it a lot. Sometimes, women have cesarean sections and they go, oh yeah, that one, she's lazy. And, something goes ping, go see who it is. And generally it is a person of color who has been given paracetamol alone after having a cesarean section and expected to get up and walk. Similarly, your experience of that is endemic. And I know it's hard when you're sick or ill to advocate for yourself, because at the end of the day, you're in that bed suffering. I've been there, your ability to advocate is decreased because you are unwell. And so perhaps get your family members, somebody you know, to help push for that. Say, look, this is the baseline. I had oxycodone last time and they told me because I needed it because this was major surgery and blah, blah, blah. But you shouldn't have to. But if you have to, do it. And I'm really sorry that that's happened. So when you get your surgery for your endometriosis, especially if you are on chronic pain medications, I don't know if you are meant to have your baseline, which is whatever it is you're taking generally for your pain. And they're supposed to give you something extra to cover that. You can't just start from everybody else's baseline, if that makes any sense. So you take whatever it is. If I haven't taken no pain medications, that's my baseline. But if you're having something already, they need to give you something on top of that. Otherwise, you're not going to control your pain.
Okay. We've got further questions here. Does pain clinic support weight loss discussions in low back pain and knee pain? So does pain clinic support that as well?
So your pain clinic is not going to be a weight loss clinic. They're two different things. However, they can both be part of your management plan. So if you know that you are overweight or severely overweight or have a high BMI, the NHS has a lot of plans that you can go on to. They will pay for your Slimming World. There are different things that you can do. I can't remember all of the names of them right now. There's something called Second Choice, I think it's called. They're available through your GP. If you are an NHS employee, they're available through nhs.net. There's some, but all of the criteria are the same. So you just go to your GP and say, look, I'm aware that my weight is affecting my back pain and my hip and knee pain. So I'm really interested in losing weight. I'm aware that the NHS has a few programs. Please, can I be attached to one of them? Don't just settle for, we'll send you to the dietitian, because that doesn't really work. So the pain programs will give you proper support, nutrition, exercise, group sessions and accountability and set ways in so that people know that they're supported, not just doing it on their own. So yes and no is the answer to that question. They can work together.
They can work together. There's lots of different things that you could be referred to that can work hand in hand.
Yeah.
Brilliant. We've got some other questions. What do you do when arthritis pain is getting worse?
It depends again. All of these questions are very subjective. So where is the arthritis? Is it functional? Is it affecting your function? That's why you keep a pain diary. What affects it? Is it movement? Is it the cold? Are you stiff in the mornings? Are you stiff in the evenings? Is it rheumatoid arthritis? Have they screened you for that? Because the management is very different from osteoarthritis. Have they categorized it? If not, go to your GP and get that categorized. If it's rheumatoid arthritis, there are medications that can help that and prevent the escalation of the disease. If it's osteoarthritis, then what exercises can be done whilst we have a bit of pain management. So it very much depends on the type of arthritis and where it affects.
But you've mentioned that a pain diary can always be really helpful in
Yeah.
guiding what next to do. If a doctor is wanting to do an X-ray to establish the source of your pain, but research says scans will show more detail in terms of the condition you have, what rights have you got to request a scan?
So again, that question, I'm not sure because I don't know what the condition is.
Yeah.
They might be looking for something particular. So for example, if it's a musculoskeletal thing, and you might be thinking it's your joint, they might want to exclude that there's a bony fracture there first. So based on that question, I don't quite know. I can't really say. It's all very it's conditional on what the scan is and what they're looking for. X-rays are good for bones and effusions. Sometimes they may even do an ultrasound rather than a scan. It very much depends on what you're looking for.
So it kind of is specific to what exactly is going on with that pain. Probably need more information about that. So
Yes.
we've got some other questions. Someone said that they exercise often, and after they do hip thrusts, they start waking up with hip pain a couple of days later. I thought it might be sciatica. The doctor said I probably had an injury. How do I actually fix this rather than just skipping the exercise? I want to address the root cause, not just avoid it. I'm in my late 20s.
So if it only occurs when you do the exercise, that sounds like, I could be wrong because I don't have all the information, but it sounds like cause and effect. So perhaps find a different exercise or gentler way of doing it, because sometimes muscles don't move and the fascia gets very tight. And then all of a sudden we decide that, we want to loosen our hips. Yeah, this morning I went to one of those stretch and relax classes and I'm in agony. But it does hurt and it can last for quite a long time after, because you're stretching the fascia, which does not have any elasticity in it, because it's what holds the muscles and bones together. However, it's got lots and lots and lots of nerves. So what you want to do is stretch those things gently. It's not going to be overnight. It's going to be weeks and months rather than days. So my advice would be to do it gently, because like I said, from the question presented, it sounds like cause and effect. Because if it doesn't happen at any other time, just be a little gentler with yourself or find another exercise that will give you the same effect. And stretch more. Stretching is something that we don't do enough of. Everybody, including myself, she says, hanging her head in shame, should be stretching every day, even if it's for 5 or 10 minutes. It doesn't matter. On YouTube, they've got a lot of videos that you can do. There's a one called Beginner Stretch, stretches for the inflexible. Don't mind how she looks because she used to be an ex-ballerina, but she gives you options. So don't, and if you do it every day, then over time you will find that that you improve. Time is your friend here, especially when it comes to things musculoskeletal.
I guess we can all incorporate that into our daily morning routine.
Definitely.
So we've got our final question here. It says that a lot of women were given pain medications in the form of some injection in the lower back during childbirth, which is now causing ongoing niggling pain in the lower back. What can one do to manage the pain?
Okay, the first thing I'm going to say is that spinals and epidurals don't cause back pain. Childbirth causes back pain. So when you think about it, you know, you've got this tight little pelvis. I'm going to pretend that this is a pelvis looking thing. And there are the ligaments that get very loose between the bones in order to stretch to allow that baby to pass through. Sometimes, you know, there are problems with realignment. Sometimes other things happen. A lot of the times, going up in the stirrups when you're ready to give birth, that can stretch the nerves in the legs and cause sciatic type pain. The type of pain you get from epidurals and spinals tend to affect your bowel, your bladder, and your legs. I'm not saying it's impossible, but it's highly unlikely that that pain that you have is due to the spinal or the epidural. So how to manage it? Again, I would recommend stretches, you know, physiotherapy. You can have like, you know, the balls that you sit on and rock your pelvis backward and forward to stretch those ligaments, stretch the muscles and get them back into alignment. But I would recommend that you start off with somebody with a chartered physiotherapist who can show you the exercises and then probably take it on your own.
Brilliant. Thank you for that. We've got someone asking for a friend. Is there any exact, please can you share some of the YouTube stretches you have mentioned? Do you know any of the names so we could put them in the chat?
Yeah, so it's there's one called Mad Fit, Natalie. It's stretches for the inflexible. Let me just see if I can find that. Yeah, that's a Mad Fit lady, stretches for the inflexible. And I'll probably send a few more that we can add to the chat a little bit later on.
Brilliant.
Have you found it?
Let's see, Mad Fit.
Yeah.
Oh yeah, I found that.
And it's really good because they do like 10-minute ones, then you can work up to the 20-minute, then to the half-an-hour ones, and then to the 45-minute ones. And I would say to anybody starting out, you don't have to start at an hour. People think that you have to do this great grand thing. Just start for 5 minutes. And if 5 minutes is too much, do 2. And then the next time, you know, over time, you'll be able to do more and more.
Yes, I found Mad Fit for Natalie. I'll put it in the chat for you, everyone.
Yes, please. Thank you.
We've got another, I think it's been put in as well. Do you have any comments about a physio versus chiropractor?
Ooh, now I know that we don't have lots of interactions with chiropractors. I am not a clinician that will say that the allied health professionals that we don't traditionally recognize have no use, because I know better than that. However, I would probably say start with a physiotherapist. I don't know enough about the licensing of chiropractors and their means because they lie sort of outside of our medical world, whereas we work with physiotherapists quite regularly. So I would probably advise that you start with your with a physiotherapist. I don't know enough about chiropractors to comment on that.
Brilliant. Thank you for this. Thank you for all. Have we got any more questions in the chat? I'm just trying to look through.
There is one about 11:53, Dr. Kemi.
Yeah. They mentioned that they've got severe arthritis in both knees. They've had steroid injections when it was really bad. And they've been told that due to their age and being very mobile, that surgery is actually discouraged. But they're in so much pain, they're in severe pain, and they're 52 years old.
So if you've got severe arthritis at the age of 52, I would probably go for a second opinion on that and see if you can get yourself a knee replacement. But again, this is just based on what you said to me. I have not seen any scans. I don't know what the situation is. I don't know the type of arthritis or your other medical conditions, which may be why, you know, sometimes it's not the actual pain that you're experiencing. If you have other medical conditions that might make surgery difficult for you or dangerous, that may be why they have said, hang on a second and wait later. So given that all of the things are as they should be and you're fit and well otherwise, and your knees are the only thing bothering you, then I would say get another opinion on that, because you can't limit your mobility at 52 because of severe arthritis. That's not fair. So, and if it is that you're not given that, you need to invoke Martha's rule and get some scans.
So then bringing in that rule that you spoke about, that we've learned about today, which is brilliant, that we can use that in our day-to-day lives, in our clinic appointments if needed. So just if you have any further questions, it'd be great if you could email healthhour@cairn.org.uk. I think we've answered all the questions in the chat at the moment. Oh, okay. We have got another one that's just come in. Do we have time for that? We could just go through it quick.
Yeah.
Another question said, any thoughts about the frozen shoulder of menopause?
Ooh, I know who that's come from. No, I don't have any immediate thoughts on that. However, I will contact my orthopedic colleagues and get back to you and put that in the chat. What I can say though is, yes, Tai Chi is very good, but if you have a frozen shoulder that you cannot move, it needs to be assessed, because we need to ensure that it is because of menopause and not because of anything else that may be happening alongside the menopause. And I will ask my orthopedic colleagues and refer that to them and get back to you.
Thank you. Thank you, Dr. David, for answering all these questions and for a really insightful talk this morning. We've got some comments saying thank you. Someone said, thank you, I appreciate your advice, that they're going to write to the PALS to alert them about their concerns regarding their treatment. So things are happening and things are changing. Thank you so much, Dr. David. I'm going to hand over to Stephen, who's going to finish off. Thank you so much once again.
Oh, what a great session that's been. Thank you, thank you, thank you, everyone. You can see from the responses, you'll see that people have really, really learned a whole lot. Thank you, Dr. Joan. Thank you so much. We can't thank you enough. You've made us really know what pain is about and how to go about it. I noted something that you said pain is a sign that something is wrong. I said, oh, wow, I had to note that down. And thank you for letting us know what to do and how to go about it. And for Dr. Kemi, thank you for always being there. We're grateful. Thank you for guiding us and putting us on track. Thank you so much. Thank you, doctors. And for everyone on the call, thank you, because you've really made today a successful one. Great session we've had about pain and how to go about it. I just quickly like to share my slide. Um, yes, that's it. And thank you. Just a moment. I believe you can see my slide. Okay, next Saturday is another day. We're going to have, as we know, it's every Saturday from 11 a.m. Next Saturday, we'll be having a great session, and it's going to be about HIV, what everyone should know about it. And then we'll be having Dr. Modest Onwambila on the day. I want us to invite friends and families. This is one platform that we tend to learn a whole lot from some of the leading health care practitioners in the UK, and you won't want to miss that. Please, to register, send email to info@can.org.uk. You come and learn what testing is all about. There's nothing to be afraid of, and how to support our loved ones. Please, next Saturday, let's make it another day. Do you want to have a safe space where you can learn resilience and talk and share your views? Please be at the Empowered Voices panel, and this is coming up on August the 13th from 4 p.m. at the Methodist Church in Manchester, Central Buildings on Holdham Street. Please make it a day. You're going to learn a whole lot about building real emotional resilience and confidence. Going to be a lot of practical discussion and strategies on how to go about issues and how to handle them For any questions, please just send us an email at dvsa@can.org.uk or call 07769311389, and someone is going to guide you on how to go about it. We really, really look forward to seeing you on the day. Please join us. It's going to be a great session. Guess what? Do you know you may be owed the Windrush compensation? And one thing I would like to say is that CAN is here to help you claim it as long as you're qualified for it. So please reach out to us. It's a free, confidential, and session will guide you on how to go about the claim, ensuring that you get what is due to you. For the next drop-in session, it will be at the Liverpool Central Library. That's Liverpool L38EW on Thursday, the 30th of July 2026 from 10 a.m. to 4 p.m. You can reach out to our advocacy team on advocacy@can.org.uk to get started, or call Christina on 07979 028 and Shola on 07853 for to know how to go about this claim. We are here to guide you to ensure that you get what you really, really deserve regarding the Windrush compensation. And finally, sexual health is really not just about testing. It's about understanding you, respecting you, and supporting you with everything that is needed, every information. So with our safe steps, we bring really free, confidential sexual health talk and services. So if you live around Lombard, Southwark, or Lewisham, please join us or send us an email at or check www.findsexualhealth.org.uk for every information needed. We are waiting for you to see that we guide you and give you the necessary information on sexual health. Oh, thank you, everyone. And that's it on this week on Can Health Hour. Please join us next Saturday for another session. We look forward to seeing you all. Have a great weekend. Thank you.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.